Thank you very much indeed for inviting me to speak on my very close to heart topic on cystic fibrosis, which I've been actually doing it since 2004. So it's been 18 years since I've been talking about cystic fibrosis in Pakistan, trying to raise this awareness and improve the care of patients in Pakistan. And over that time, there are obviously many challenges, and this time the title given to me was to talk about the challenges of measurement and diagnosis in Pakistan. And I think one of the challenges that I can see this morning is actually getting to the auditorium. And that itself is something, congratulate yourselves to be able to get here. So it's not your fault, it's the ones who are not here who can't actually hear me, so it's no point me saying it because they can't hear me. But it is basically takes the initiative that you have to take. You have to make the effort to do something, and I think this is what I've been trying to achieve in the last 18 years or so, and inshallah, I haven't given up. We'll get there. I've semi-retired, but still carrying on doing my cystic fibrosis, and I started my journey from Children's Hospital, and that's where I am still at present. And in the process, that Children's Hospital, the whole building moved in 1997 to another site, and this is our new building, and this is yourself here as well, where I've got very strong links for a long time. So we will discuss the challenges, but don't be put off by the challenges. I think you should all take this opportunity to deal with them, take them up as opportunities, and in particular those people who are working through the various grades of training. I think it's a great opportunity for you to possibly even take a part of the cystic fibrosis or challenges, or maybe some other disease based on the similar principles, and address that and make that your ultimate goal in achieving that, and get your work done, get your publications, and excel in that field. And I think that will ultimately improve the care of patients with various diseases, and as I've talked about cystic fibrosis, hopefully inshallah cystic fibrosis as well. So with cystic fibrosis, will the slides turn please? So cystic fibrosis basically, in Pakistan, it is probably not a new disease because back in 2004, when I did my first lecture as part of the BPA Biannual International Conference, there was a publication already from Lalhore Hospital, and there was a youth medical college from Sarhad at that time, it was used to be called. The publications were already there that there is a population of CF patients in Pakistan. But that was all. There was only just a few publications mentioning there are occasional patients here and there. And over the years, that number has actually increased. And I deal with CF patients on WhatsApp group. They all come up personally with any problems. I try to deal with them online for them. So discussing this, I may be mentioning some medications, some drugs, etc. I just want to say that there is no conflict of interest at all. Any names mentioned are purely for educational purposes or to illustrate the problems and the challenges that we have in Pakistan. Coming back to the CF, CF itself as a disease entity was basically identified back in 1938. So it's about 84 years old disease as itself, and it was the Dorothy Anderson lady who described it in a publication. And before that, people as here at present are being treated with recurrent chest infection as a separate thing altogether, celiac disease possibly for malabsorption, and nobody tried to link in together that the two together could be cystic fibrosis. But I was I'm just currently on an official visit for the Royal College of Paediatrics and Child Health, and we just done a mock exam for the MRC-PCH in Lalhore CMH, and hopefully we'll probably be conducting the real exam in a couple of months' time. And in that, there were some candidates who appeared, and there were some cases that sort of fitted into cystic fibrosis, failure to thrive and malabsorption and all those things. And I was really pleased to hear that the candidates came up with diagnosis of cystic fibrosis as a part of differential diagnosis. So people started thinking about it, and I think to me that was quite a great thing. So it's only been 1938, and then it is a genetic disease, as you all know. And the genetics were actually being worked out back in the 40s when it was published. Looking at the family, people knew that it was autosomal recessive condition. But it wasn't until 1985 that people identified that this is located on chromosome 7, the long arm of chromosome 7. And another 4 years after that, they identified the CFTR gene. And that was a huge discovery because it was a lot of excitement in the CF population that now that we know what gene it is, there may be some treatment with gene therapy and cure for this disease. And obviously that still has not happened, but there are a lot of other things that have happened, but we're still looking for the particular specific gene therapy. But this is sort of, at that time, all the genetics and specific mutation-related things came up, and now we know there are over 2,110 different mutations that can account for CF. In Pakistan, unfortunately, we are only able to check Delta F508, which in Pakistan population so far only accounts for 1/3 of the patients. The other 2/3 have different mutations. So therefore, there's a lot of work to be done on mutations. And I'm pleased that we currently have a PhD student in Lalhore who's looking into the genetic mutations for cystic fibrosis. And she had accompanied me in Children's Hospital last week, so Moda yesterday, and also here today to take some samples to actually look for other mutations other than the Delta 508, and hopefully we'll start producing that locally as well. So it was this CFTR, which is the main problem, that we have the normally we have the chloride channel transport. This is what the CFTR gene does, where the chloride are passed into the epithelial surface from within the cell, and with that it brings the sodium, and sodium chloride then draws the water, and we have nicely hydrated surface area there, which makes it nice runny, and if any organisms, any dust or particles are there, they are held in there and then expectorated out. But in the CF population, that channel is closed. So there is no chloride going across, there is no sodium accompanying it, and that layer that becomes quite dehydrated. And that's what produces the thick mucus, blocks up all these small airways, and all organisms that are there then cause infections. So that is the main defect, and those 2,110 different mutations are now subclassified into various classes, and there are at least these 7 classes. So this is the normal channel where you get the chloride transport. This is class 1, there's no protein made at all, so therefore you can't do anything with it. And this is the Delta 508, the class 2 mutations, where the protein is made, it's a defective protein, it gets stuck onto the Golgi apparatus and doesn't make it to the surface epithelium, and therefore you do not have any sodium conductance at all. And then these are the gating mutations, where you get impaired gating, so the protein does make it to the surface, but it is still closed. So it's a closed, but it just gets there. This is where you get the protein on there, but there's only fewer numbers, it's a decreased molecules of chloride that can go across, and there's the less protein made. This class 6 is where you have protein that is mocked up quickly, denatured quite quickly, and therefore it doesn't last very long within cells. And this is the one where the messenger RNA is missing as well, and therefore this is very much equivalent to class 1, where there is no protein made at all. And there's been a lot of work on these class 2, 3, 4 ones, the conductance one, where to improve the conductance of these chlorides, and there have been since 2012, there have been a lot of different drugs produced for these, and this was 2012, 10 years ago, our Caftor came across, and now we have Caftrial and Trikafta, which is now licensed for children over 6 years of age. So about 90% of our CF population in the UK is on one of those medications at present, and most of these over 6 will be now on Caftrial as well. This medication, when it came out, is about 2 or 3 crore rupees a year for life. So it's a huge cost. The price is coming down, but it's still not available in Pakistan. We actually asked the pharmaceutical agencies, and they are not able to get that to Pakistan. There are also Pakistani laws which are challenges as well, that you can't get foreign things imported into Pakistan, and that's just not all the ordinary products that people use at home, or also the drugs as well. So it's a big challenge from that point of view as well. The life expectancy of a patient with cystic fibrosis, this is what used to happen in the West in 1940s. Most children died in infancy and definitely before preschool age. And from that, what they've done is now we are living into late 40s, 47 is the median survival rate in the UK. It's probably slightly higher in Canada, but that's what is happening at the moment. And what resulted in that one, all these things that we actually can do in Pakistan. We may not be able to afford these mutation-specific medication, but we can do the physio, we can give the creon, although they are imported, and people have, again, these are the challenges, the legal challenges in the government to get these imported. We have anti-pseudomonal treatments, etc. The resistance is a big problem. Hypertonic salines is not available commercially, but the pharmacists in the hospitals make it. So there are ways to get around these things. And if the West could get the survival curve from preschool age to 40s without the mutation things, I'm sure that can be achieved here. Unfortunately, that is not the case at the moment. However, I'm pleased that there are adult patients we see in Pakistan as well, so the survival can be better. They may have different mutations, and all different mutations may have different phenotypes as well. But challenges are there, and we can address those things. So coming back to specific challenges, and this is for people who are working in laboratories, for example, in biochemistry, microbiology, and genetics. These are the opportunities rather than challenges for those people to take up these challenges and convert them into opportunities and have some output from these. So first of all, diagnosis. So we can diagnose cystic fibrosis based on clinical grounds. 65% or 2/3 of the patients have respiratory recurrent chest infections, they have malabsorption, failure to thrive. And if people can put two together and come up with CF as one of the differential diagnoses, then it may make life easy. If you don't think about it, then there is no way that you can make the diagnosis. That second one is sweat test, and there's challenges about that, and I'll sort of discuss all these together in a minute, and then the genetics as well. So coming to the clinical side of things, there's a lack of diagnosis, there's a lack of awareness. If you don't think about it, you're not going to make a diagnosis. So, well, first of all, you've got to think that CF could be part of the differential diagnosis where people have recurrent chest infections and they may have failure to thrive. Of course, I've seen lots of CF patients in the initial stages being treated for TB, because that will also cause the same things as well. There may be immune deficiencies, there may be other things, but you need to have that in your differential diagnosis to make that possible in the future as well. So please do think about it. And how can we look at this? This patient and doctor. The doctor is obviously thinking about differential diagnosis in patients, having gone through many other various local doctors, PACs, etc., and all that, who may be treating with various other things, homeopathic doctors. So all those things happen, and the diagnosis is made late. So we need to raise the awareness of the condition within the average population as well. And this does present with multi-system disease, and these are the common things, about 15-20% with the columalias. So those surgeons who are working within the tertiary centres doing GI surgery, they will be quite aware of it, they will be doing a lot of operations, but we then need to follow those patients through. If they do survive, which they are, luckily nowadays, survival is much better. And think about those symptoms in those patients and think, could it be CF or not? So that's the clinical side of things. And that, obviously, undergraduate education, postgraduate training, there should be opportunities in that, and raise the awareness of the clinician within there. And instead of symptomatic treatment, somebody coming with cough, or repeatedly coming with cough, don't just give the cough syrup. Look at the cause of their cough, and look at the cause of their failure to thrive, rather than giving supplements or something. And I think that is up to the doctors to make those diagnoses easy. And then educate the patients. If, for example, they don't get better, come back to you rather than go to another doctor. And people do shop around. And I think this is the education of the whole population, where if they don't get better within the 24 hours with 1 or 2 doses of the medicine, they say that doctor is not so good, I'm going to move on to another one. And I think we need to be a bit patient as well and explain and take our time to explain to the doctors. Patients very often actually complain, and that's what, when I was preparing this talk, I asked my patients, I said, what do you think? What do you face? And they said, nobody listens to us. And that is our doctor's fault. We can improve on that. That's a challenge for us. Within 5 minutes, patients in and out. CF takes longer time. I'm doing a CF clinic today. We've given half an hour each patient. I know you can't do that, but at least listen to their problems and empathize with us as well, see what they're going on, and explain them what it is. I know patients have been given Creon, saying take 1 capsule 3 times a day. Absolutely no explanation, no relationship with the food intake, no relationship with saying if they still have malabsorption, you can increase it, decrease it, or adjust the dose. There's absolutely no education at all. That's our responsibility to actually educate our patients when they are diagnosed. And then there's multiple medical opinions that say they do move around. So I think all these things are on the clinical grounds. Now, with regard to the sweat test, that is still the gold standard. Although we got gene mutations, now we can do those as well. The sweat test still remains the gold standard. But there are difficulties in that. That person who is doing the sweat test, there are supposed to be some standards they need to meet, they have to have the training. So it is usually, I have CF patients come in with sweat test, and correct me if I'm wrong, they normally say, sorry, we haven't been able to get enough sweat, we haven't been able to process it. So it's failure of the test many times, and that we need the training of the person performing the test to make sure we can get that better. There's lack of standardization, and if I give you a few examples of that, this is one of the sweat test reports, and on that one it says normal is up to 60 to 80 is borderline, and more than 80 is positive. And then it says this is only a screening test. So it's a screening test, it's not a diagnostic test. And what they recommend is that you need to do quantitative tests. And when I asked them to do that, they said, sorry, we don't do it. So this is conductivity test. And look at just the numbers. I'm just pointing out the problems with the standardization. This is another sweat test which some people may recognize. It's from here, and the reference ranges are totally different. This is Children's Hospital report. This is another one from our a sweat test. This is the publication 2004. They were taking a cutoff point of 40 millimoles per liter. So there's 60, same, that first report was our this one is our This is from our cutoff point was 50. So there is no standardization, and therefore we need to know what is the actual proper thing. Labs need to talk to each other, collaborate with each other, set the standards to have the proper test. And these are all different things, and quality control is very important. In the UK, for example, a person who does not do at least 1 sweat test a week is not allowed to do the test. And the labs who don't do many a week are not able to process the sample. So all our region, there's about 100,000 population in Birmingham, or more than that. They actually have a Midlands CF center, regional center in Birmingham, and we do all the processing sweat tests in our center. They are taken elsewhere, but not processed. So it's only a single laboratory who has good quality controls who actually do it. So we need to standardize on that. Genetics. Diagnostic sweat test inconclusive, where prenatal diagnosis may be useful for future pregnancies, and also where obviously in our setup there are cousin marriages, it can be useful to have genetics known to that, so we can screen the siblings within the old people who may be getting married and advise them. It's like thalassemia, it's the same inheritance, so people can be advised on those things as well. But in Pakistan, we can only do at present Delta 508, as I mentioned before. There are over 2,100 different mutations, and they are expensive and unavailable. And I hope when more people want to do it, there is more setup, then it may be cheaper and more affordable. But those are the issues with that, those are the challenges. We don't actually have those facilities at present. Now, coming to the management aspect of things, as I said, this is multi-organ disease, and it can present with various things. 80 to 95% of the people die of respiratory failure with this condition. So most of us would like to make sure that the lungs remain healthy. And if you can keep the lungs healthy, then they are likely to survive longer than those who have their damaged lungs right from the beginning. And from the respiratory point of view, there's a lack of pediatric physiotherapy input. Obviously, Children's Hospital has now got dedicated CF clinic. You do it on Fridays, I presume, with CF dietitian and CF physiotherapy available as well. So things are getting better. But we generally, in the UK, for example, in the West, you have physiotherapists who are degree holders, they train and they subspecialize in pediatrics and then subspecialize in CF. So we don't have that. We need to have that training so that we can have right people advising them. There are lack of devices. There are different techniques of doing physiotherapy, and these are sort of percussion, which most people are doing. These are baby PAPs, which are almost not possible or available in Pakistan. This is a bubble PAP in the middle, with just a column of water or some other liquid, and children blow through it, and that causes the CPAP effect. These are acapellas of different ages, and these are the CPAP things, the vibratory things to actually loosen up the squishes. And then this is aerobica, which is similar to a cappella, and these are the vests which are being promoted, but nobody really knows how to use them. We're trying to, at the moment, work with one of the physiotherapists for our hospital to do a video recording so we can put up on our YouTube channel for education as well. But people have acquired some of these quite expensive devices, but they don't know how to use it. So those are the challenges we need to take up. And once we actually do have it, they don't adhere to it. A lot of people I've seen in the last 2 clinics over the last week or so, how often do you do physio? जी डॉक्टर साहब टाइम नहीं मिलता, नहीं कर सकते हैं, बिजी होते हैं. So actually, the ones who came with their moms and dads, I told fathers, I said, look, why don't you do some physio while mom is doing the cooking and making breakfast in the morning and help them out. So I think share of responsibilities with CF children is very important because it is a very time-consuming process. The other problem we get is, as I say, respiratory infections. And one of the biggest issues is getting the samples to see what sort of organisms they are growing. And I repeatedly hear from my group to say that when they take a nice good sputum sample, take it to the lab, they reject it. They say it's not empty stomach sample. I don't know where that's come from for CF. I know people do early morning sputum culture for TB, for example. But there is no link with somebody being or having to remain fasting until they take the sample. So labs need to work with our clinicians, need to tell the labs that if it's for CF purposes, please do process the samples. But how do they take the samples? We used to use cough swabs, which is the child just has these petri dishes provided in the clinic by the physiotherapists. They do all these things for us, and they ask the child to cough on cup plates which go direct to microbiology, and they culture them. Or they can have what we call the cough swab, which is just a throat swab, put on the back of the throat without touching the oropharynx, and ask the child to cough. So cough is actually the lower air coming up with the bugs, which will deposit them on the swab, which then can be cultured. And the cough swab concept is not present in Pakistan. It's easy to do it, but they say we never heard of it, therefore we don't want to do it. We're trying to teach the parents how to take it. And then second best is actually cough, the throat swab itself, where you actually do it, but you could just end up with upper respiratory tract infection rather than lower respiratory tract infections. That phlegm is beautiful culture to send if we can achieve it. I know it looks horrible, and you probably all had breakfast, so I don't want to make you sick, but that's the best sample that anybody can take. And then we have the induced sputum, where children can be given hypertonic saline with the physio help to do the physio after the hypertonic to produce the sputum and send that. And then obviously very invasive bronchoscopic and alveolar lavages, etc., which we can't do on everybody. So there are different techniques that can be done, but we need to be educating our microbiologists, our own physiotherapists, or the patients, or for their families, to take the proper sample. And once we got the sample, they're not processed. I mean, these sample goes there. If it's a throat swab, they'll probably check for strep A or something like that, and they say it's negative. They won't look for Pseudomonas, they won't look for fungus, or they won't look for other things. So we need to actually tell them this sample is from a CF patient, and therefore they may be looking for other organisms that are commonly found. So sampling can be processed, the timing may be processed, during the time they're taken and sent to the lab. And then antibiotic sensitivity reporting can be issued. All different laboratories report different sensitivities. I'm not sure that this is pharmaceutically led, that they actually say to our drug sensitivities, so that is the only one available on there, and therefore the doctor is directed towards prescribing their antibiotic, for example. So I think those we need some sort of standardization. We need to see what organism, if microbiologists are here or aware of the sample coming from CF, they may actually set up some of the other things. And when they actually do set up the culture, we do get multi-resistant bugs. And that is another thing, that sometimes they are so resistant, there is no alternative. There's no antibiotics available to treat them. And that is where I think there's a national drive not to use antibiotics in all the new population, only use it when necessary. And the other big thing is about treatment. Once you know what antibiotics to give, people give it for 5 days, people give it 7 days. But please remember about the duration and the doses of antibiotics is we have a low threshold, even with viral infections. If they persist beyond 48 hours, we treat them because they can get bacterial respiratory tract infections. So it's a low threshold to treat with antibiotics, give them high dose antibiotics, and we give minimum 2 weeks, sometimes longer, sometimes we have given 3 months, but that is clinician led. But minimum 2 weeks. So low threshold, high dose, minimum 2 weeks. But people don't comply with that. They finish after 5 days, or the cough got better, and then a week later they get returning of that cough again, and they're back to square one again. Unless they complete the whole cycle, process, and duration of the antibiotics, they're not going to get better. They repeatedly get these infections. So please do educate them and do ask them to take the antibiotics for the whole duration. Again, the threshold for oxygen. I know a patient, I just visited one yesterday with 86% of oxygen sitting there and unable to do anything. And people, so that's fine, you've got cystic fibrosis. No, they got cystic fibrosis, they got lung problem, please make the life easy, give them the oxygen, get that over 90%, so their quality of life, their body feeling, etc., tiredness and energy, etc., can come back. Otherwise, they will all remain tired, they can't do anything. So, over 90%, we always advocate giving oxygen. And here people are actually walking around with a respiratory problem with under 90%. So please look into that as well. And inpatient, outpatient care is totally different setup. We don't have regular reviews here, for example, whereas in the West they have every 2 or 3 months they get a review by the physiotherapist, by the dietitian, by the clinicians, they have a sample sent, they have a lung function done, and it's good monitoring. But unfortunately that setup is not possible at present, but it isn't impossible in the long term. We can work towards it and make it possible for the future. Availability of lung functions, yes, it is costly thing for people, have to pay for it, and people need to teach them how to do it, but sometimes there's no standardization with that either. So when people are doing it, please make sure that you actually train. In the UK at present, you have to have a course in spirometry type things to not only do it, but to interpret it. So unless somebody's attended the course, you can't officially interpret what the spirometry is. It is taken so seriously because it depends on the child's technique, the way they're doing, and the person doing it needs to know the limitations of it as well, and the report on that as well, to say this is the circumstances and condition under which it was done. And then coming to the medications, once it's done, I've just sort of highlighted, and that's what I said, I have no conflict of interest in these things. And this is just to highlight, these are some of the common IV antibiotics we use, but sometimes the bugs are resistant, sometimes these medications are expensive, people can't afford it, and we can't give. So we need to make these available. And if there is a national drive to help children or whatever, the health card or whatever, then these should be made available to these children. Lack of nebulized mucolytic agents, hypertonic saline, 70% is the best one, and it's not available most of the time, and medicine made, people have to pick it up every 10 days or 30 days because it's locally made and it doesn't last long, and they sometimes have to travel 2 or 3 hours to come to the pharmacies who are preparing these. Alpha donase, not available at all in Pakistan, which is commonly used for over 6 years of age in UK, for example, or even younger children if they need it. Nebulized other antibiotics, Toby, Caistin, Colistin, not available in the inhalation, and when people are using, they're using IV preparation, etc., very expensive again. So these are the challenges, financial challenges, and that's where the children with CF need, or their families need support as well. When you come to respiratory support, there is very little that sometimes people have or go by. I mentioned about the oxygen in the beginning. They can have nasal oxygen if the oxygen is dropping. They can have different sorts of BiPAP or other things, and these can be supported for the time to ventilation. But families get stuck when child is not getting better. They don't get any medical advice or the right equipment, and they either, it's quite right obviously if somebody's lungs are not very good, and you might advise them, sorry, ventilation is not an option for you, but it needs to be done in a sensitive way, rather than say, sorry, take the child home. And that's what I've heard many times as well. But sometimes it is an acute infection on the background of a good lungs, the good function. That child will get better with ventilation, but needs to be explained. So not all CF patients on ventilator will remain or die on ventilator, they can survive. And one of the things we actually use in children, we don't normally need lung transplantation, etc., but who actually do need lung transplantation on the waiting list, they may sometimes go on to non-invasive ventilation with BiPAP, etc. So those modalities sometimes may not be available or may be expensive to deliver. Other nutritional components, pancreatic insufficiency, about 85% of the people. Creon, not available, not sort of tested for sometimes, or test itself costs 7,000-8,000 rupees. But clinically you can make the diagnosis. It's for oily stool, the large stool, the pale stool, the smelly. Then you can say, well, this child is likely to be, and you can document that on clinical grounds. They got pancreatic insufficiency if they can't afford it. If you really want it, that is fine. If you suspect it's Delta 508, for example, and they are likely to be, there are some children who may be efficient in the beginning, but become inefficient later on. So we check that every 6 months or every year, or when they become clinically symptomatic, we do check fecal elastase 1 again to make sure that we actually give them that medication for the right time. And then when people are having Creon, like I said, they are given, take 1-3 times a day. No, it needs to be adjusted with the meals, it needs to be adjusted with fat content of the meals, and they need to be shown what to look out for, to monitor the stool, and use the dose properly. So education is a huge challenge there as well. Calories, people fail to thrive, they do need extra calories. CF patients generally need 25 to 50% extra calories because they're burning in fighting the infection in a catabolic state and malabsorptive process. So they need extra calories, and some of these calories are very expensive to produce or may not be available. And that's where the local dietitians can guide them what is available locally as calorie supplements. And fat-soluble vitamins, A, D, E, K, they'll be deficient of those if they're not supplemented. And some of these preparations may not be available, they may be available in different units or strengths, and they need guidance on those specific things. We check their A, D, E levels every year. Very expensive. A and E levels are not available in Pakistan, and when they are, it's many thousand rupees. I think somebody mentioned 25,000 rupees for it. Obviously, not possible to do it. Vitamin D is easily done, I think it's 3,000-4,000 rupees, but you can do that and monitor that. But they do need advice and guided by what preparations may be available. And if comes to supplementing the NG feeding tube, gastrostomy button, gastrostomy tubes is the option again. There are some surgical things, may be expensive, may not be possible, or they need to have the obviously full supplements going through it. So we need to address those things. These are the challenges that CF patients facing on a daily basis. And then coming to the team, we don't actually have a multidisciplinary team, but the teams consist of all these people put together. They collaborate with each other, they coordinate their services, they talk to each other, and don't be ashamed of asking somebody, microbiology, please let me know what to do, when you're stuck with the sensitivity, etc. But that teamwork needs to be developed and carried on. And I think currently in Children's Hospital, I'm pleased at least we got 3-4 people. I think a few years ago, in 2016 or 15, when we had a CF symposium here, we had the pharmacist on board, we had the microbiologist on board as well. I think they dropped off the list. Thank you. We'll love to have your continued input. But those things we just do need to carry on working with them. And then data collection, working, collaborating with other centres within the UK, so we know what mutations, what problems, how they're dealing with it, talk to each other, have that link with each other, and I think that is very important. And we're currently trying to see if we can set up some sort of foundation society or trust in Pakistan as well. There are legal challenges to that as well, and I'm just discussing that with somebody yesterday, and they said they asked for 2 crore rishwat for it. And sad, that is where we are at present, and rishwat becomes a norm in this society, and that's where you can't get anything done at all. So in summary, I won't go through all the list, but from clinical, diagnostic, sweat testing, genetic testing, management, monitoring, respiratory antibiotics, all these are challenges. Some challenges easy to address. Some challenges need to be taken up by the budding pediatricians to use as an opportunity to excel in their field, in their interest, in hope to help the people for the future. So thank you very much indeed. And this is our CF Trust, this YouTube, that we got over 50 videos recorded for the families and also for junior doctors. So they aimed at both levels. So you can go and look for Pakistan Cystic Fibrosis Support Network, and you come across those videos. Please do share, do comment nicely. I have one person who failed MRCP in gender in December, and he just is chasing me around everywhere, my YouTube, my personal emails, sending me all the nasty messages. So please don't do that. You can send those messages personally to me if you want, but not on the group. Thank you very much indeed.